Morning, everybody. Appreciate you getting up, or giving up, I should say, a Saturday to spend a little bit of time with my good friend Matt Galsky and I. I'm a professor of urologic oncologist by training at Baylor College of Medicine. I direct our multidisciplinary bladder cancer program, and my good friend and colleague Matt Galsky is professor of medicine. He's a GU medical oncologist, co-director of the Center of Excellence for Bladder Cancer at the Tisch Center in New York at Mount Sinai, and we'll go ahead and get on with it. We're grateful that this is being brought to you by CancerNet. It's supported by an educational grant from Pfizer and Astellas Pharma. Credit is available across the spectrum of professions. If you want to get CME credit, as I suspect most of you do, you'll get a link after the program, and you've obviously got a lot of time to complete that. If we're discussing any unlabeled use, we'll mention that throughout the talks, and these are our opinions. Matt and I have developed this content completely independent of any pharma input. Although we, as you can see, this is our disclosure policy, and these are our disclosures. And we'll mention these along the way if there's any relevant conflicts of interest. These are our objectives today, to summarize the diagnosis of muscle-invasive bladder cancer, and in particular, integrated therapeutic options for this disease state and this rapidly changing and frankly quite exciting field for the multidisciplinary community. This is our agenda, and I'll go ahead and get right into it with a case. And I will, full disclosure, I'm in the midst of counseling this patient with one of my medical oncology colleagues in the Texas Medical Center. He's 61 years old, never smoker, no occupational risk factors, was diagnosed with T2, so muscle-invasive urothelial cancer, no high-risk features up on the left anterior wall. He's got just a couple of comorbidities which are well controlled, and a slightly decreased GFR, and that becomes relevant in terms of choice of therapies. And then, as is my custom, I take the patients back to the operating room and restage him. And you could very easily see the resection area. And there was a little raised, high-grade appearing tumor on one side of it. I resected that. That was T1 high-grade. We are, as many folks are, doing MRIs and PET CTs, and I'll show a slide about this VIRAD staging. The VIRAD 2 indicates that it's into the lamina propria, but not the muscle. But keep in mind that we've got pathologic proof of muscle invasion. No evidence of metastatic disease. The MRI will give you some readout on lymph nodes, and then the FDG PET CT was negative for metastatic disease. So think about this as we go through, at least as I go through my lecture. We'll come back to that and see what you think. These are the treatment options to consider. And there's a poll there that we'll come back to at the end, and you can see the options there. And okay, so we'll, guess I can close that maybe. Yep, okay. And there we go. Okay, so I'm going to get right onto it. So what are we talking about? This is the TNM staging system for bladder cancer. Really, the T stage hasn't really changed much over the years. Some distinctions are we distinguish between superficial and deep involvement of the muscularis propria, microscopic involvement of the perivesical fat versus established, and this would be a gross description. So if there's no gross evidence of involvement of the perivesical fat, but the pathologist sees it under the microscope, that would be T3A. And then T4 is invading any of the adjacent structures. And T4B is what we would refer to as unresectable, either out to the pelvic sidewall or involving adjacent structures. And those patients really need to be treated with systemic therapy and then kind of think through local control. This is the lymph node staging system. This is quite relevant. N1 is a single lymph node in the true pelvis distal to the common iliac artery. N2 would be two lymph nodes in that region. And then N3 would be lymph nodes in the common iliac. region that is a slight change from previous staging. And then we talk about M1 nodes, typically in the retroperitoneum, and then visceral metastatic disease. So I mentioned that I would talk about VIRAD. So this is, I think you're probably familiar with the PIRADS staging system for prostate cancer. This was developed along a similar methodology, published originally, I think, some 8 to 10 years ago. And I'm not going to get into it in any detail, but we do a multi-parametric MRI, and what we're talking about with muscle-invasive bladder cancer would be 3, 4, and 5. So I mentioned that our patient has a VIRADS 2 lesion with no evidence of muscle invasion, intact muscularis propria on the diffusion weighted. This is a VIRADS 4, which is extending beyond the muscularis propria, and then I think I've got VIRADS 5. I think that you could see from the back of the room that this is a locally advanced bulky tumor, and that's going to absolutely require some form of neoadjuvant therapy, and then we go from there to see what the response is. So this is the clinical spectrum of what we're dealing with. About 15 to 20% of patients, and let me go back, sorry. About 75% of patients present with non-muscle invasive bladder cancer. That's what we urologists deal with every day. And about 15 to 20% today, maybe a little bit higher because we have lots of new treatments for these patients, will ultimately progress to a muscle-invasive bladder cancer. But the vast majority of patients who have muscle-invasive cancer present with that as their first manifestation of the disease. We're talking today primarily about curable disease states, so that would be organ confined or non-organ confined, locally advanced, but still resectable. And then small volume metastatic disease, so N1, N2, we will treat, and Matt may go into this, N3 and M1 retroperitoneal nodes without evidence of visceral disease with systemic therapy. And then, depending upon the response, we may come back and consolidate with surgery or radiation therapy. But the vast majority of patients, treatment failure is manifest by distant metastasis, lung, liver, and bones. And if you, in the untreated state, about this will occur in at least half the patients without additional therapy. So this next to last bullet point, present at the time of cystectomy, is really the rationale for combining perioperative therapy. So this is the AJCC prognostic groups, and it's worth just mentioning that so stage 2 would be, these are all lymph node negative, presumably muscle confined or clinically muscle confined, a little more locally advanced. So as I mentioned, T3 into perivesical fat, adjacent structures, but still curable. And then the more serious, so N1, it's important to note that M1 still considers to be stage 3A, that is a change that occurred a while ago. So you'll see those patients often are included in neoadjuvant trials, and then more extensive nodal disease is more advanced stage, and that's definitely always going to require multidisciplinary management. This staging system is absolutely prognostic. So this is outcomes that are pathologic stage, and that's always going to be based upon radical cystectomy. And you can see that patients who have non-muscle invasive disease do really quite well, but even cancers that are confined to the muscularis propria that are node negative, they have excellent long-term survival. And then when you get into more locally advanced, those are the patients who we need to kind of double down on our treatment and constantly looking for improvements. Lymph node metastasis is a big driver of outcomes. You see that there on the left. And even the number of positive nodes has an impact on outcomes. So if you look at a patient who's PT2N1, so a single node confined to the true pelvis, those patients have a 50% 5-year survival probability, and that's held up over time. And then even the number of lymph nodes removed, and for surgeons, that really is a reflection of the quality of the node dissection. So in a trial that we published about a year and a half ago, the average number of lymph nodes removed was even just confined to the true pelvis was around 24. So that's really kind of the current metric for quality for both the pathologist who's looking for these lymph nodes and the urologist who's removing them. This is a nice paper. I was looking for something that would sort of summarize our approach, and this was published just last year. And Matt's going to get into this in a lot more detail. But we have cisplatin-based neoadjuvant chemotherapy. 2 large clinical trials established this as a standard of care in combination with radical cystectomy. A number of trials have looked at immune checkpoint inhibitors alone, and as you'll hear, in combination with both chemotherapy and antibody drug conjugates, and then targeted therapies in select patients who have things like, for instance, FGFR3 alterations that can be specifically targeted with drugs that are FGFR inhibitors. And then we'll talk a lot about the adjuvant space, where platinum-based chemotherapy may still have a role, again, immune checkpoint inhibitors, and we'll talk a lot about the biomarkers and specifically ctDNA and utDNA. So there will be a little bit of overlap between Dr. Gowski and I, but so I won't spend a lot of time on things where there are overlap. But we have FDA-approved adjuvant immunotherapy with Nivolumab. This was the Checkmate 274 trial, which showed with comparing in the adjuvant setting in patients with persistent muscle-invasive disease if they'd had neoadjuvant therapy, or more locally advanced if they did not. A clear benefit to adjuvant immunotherapy for both DFS and OS with Nivolumab, and that's an approved therapy. And you saw the same thing with adjuvant pembrolizumab. This was a trial called the Ambassador trial that was conducted within the cooperative group. So we have 2 immunotherapy drugs that have shown a benefit, and those clearly remain options for our patients. The field of bladder preservation has just really accelerated. There's a lot of clinical trials going on here, and there's a few things driving this. One thing is a perception that radical cystectomy is a morbid procedure, and there's no question that it is associated with about a 15 to 25% major complication rate. Virtually all of those can be managed and resolved. It does have a small mortality risk within the first 90 days, so it's a serious procedure and undertaking, and so that's driven part of this, but also we've just gotten a lot better with our therapies and combination therapies. But just to sort of take a big picture look, radical TURBT, oftentimes if we have a small, less than 3 centimeters, no CIS, and restaging is negative, those patients may be good candidates for bladder preservation. That they don't come along that often, but they're out there. Partial cystectomy, and just think back to a second to the case that I presented. Partial cystectomy is also an option if it's on the anterior wall or the dome. And again, 3 centimeters, primary disease, first occurrence, no evidence of CIS adjacent or remote. So that's an option. We don't do that very often, but we do kind of think about it and select patients, and I've given you the criteria there. And then external beam, generally in the past, we've excluded patients with bilateral hydronephrosis. I think because the concern about the bulk of the tumor, although in a clinical trial that I'll show you, we have included those patients. And historically, patients with multifocal CIS, again, think back to our case, has generally been excluded because the radiation typically doesn't work against CIS. So they're going to be looking at at least intravesical therapy if they have a complete response to chemoradiation therapy. So this is our current clinical trial within the Southwest Oncology Group. This is a collaboration with NRG, the radiation group. We designed this a number of years ago. We've completed accrual to it. It has a novel endpoint of bladder intact event-free survival, a host of secondary endpoints, and a lot of TM. This will report out I'm hopeful within the next 12 months. It's the largest bladder preservation trial using trimodality therapy to date. We've enrolled 459 patients. And I think regardless of the outcome, that will likely be some established a standard of care. The question that we're asking is combination chemoradiation with or without a checkpoint inhibitor, in this case, atezolizumab. This is a collaboration we have with Genentech. And then our newest trial, also being conducted within the NCTN, is Leslie Ballas' trial, where we're asking a question about, we didn't include neoadjuvant therapy in the 1806 trial, but this is asking a very specific question about patients who get standard of care neoadjuvant therapy and have only residual non-muscle invasive bladder cancer. Can they be managed with radiation and bladder sparing? So this trial is active and open. If you have a center near you, please consider. So these two trials, and there's lots of other going on, will get us a little bit closer to precision around offering bladder sparing. So I was asked to talk briefly about genomic profiling, and this is something that I've been involved in for quite a long time. The TCGA is the Cancer Genome Atlas Project. This was funded by the National Cancer Institute. They looked at 33 different cancers, including muscle-invasive bladder cancer. And I would argue that this still is sort of the standard out there, although a number of groups have done beautiful work and published. The beauty about this is it's all in the public domain. It's been downloaded hundreds of times and has really served as a benchmark for translational science in this disease state. But one of the things I wanted to highlight is about 13% of patients had UC, urothelial carcinoma, with variant histology or histologic subtypes, squamous being the most common. We see adeno, although we didn't see it in this. Micropapillary is a particularly aggressive form of high-grade disease. And so typically patients who have a majority of these histologic subtypes have not been included in our clinical trials. And maybe we'll have a chance to talk briefly about that at the end. Just a word about outcomes with urothelial variant histology. They're typically associated with more locally advanced disease and worse outcome. And this is just one paper that highlights that. And so it's very important that you have access to an experienced pathologist, maybe a GU pathologist, who's quite familiar with this histologic variation, and because these can affect decision-making about treatment. So back to the TCGA, this is what we refer to as a heat map, and it's describing mutation and amplifications. The amplifications are here at the bottom. I think the main take-home message here is that P53 still is the most commonly mutated gene in invasive bladder cancer. These next few here are what we call chromatin modifying genes. PIK3CA, proliferation marker, our friend RB1, which is typically altered in this case 17%, roughly about a quarter of the patients. FGFR3. Now, normally we think of FGFR3 alterations in non-muscle invasive bladder cancer, particularly low grade, but you also see that in high grade. You see it in metastatic disease, and that lends itself to targeted therapy with an FGFR3 inhibitor. Mutation burden is quite high. This is what you're looking at here. And actually, this heat map looks like high to low. Bladder cancer is one of the most frequently mutated cancers across the spectrum of the cancers that were studied in the TCGA, and that often lends itself to immunotherapy approaches because of the high neoantigen load. We described 5 different molecular subtypes, and so this is now RNA-seq, so this is expression profiling, and I just put this up here to demonstrate the heterogeneity of muscle-invasive bladder cancer. All the patients were required to have predominant urothelial, chemotherapy naive, and yet you see this amazing biologic variability between these these expression subtypes and their prognostic, as you can see here. So that's the short version about genomic profiling. So this is where there'll be a little bit of overlap. I'm moving on to the biomarker part of the talk. So this is IMvigor011, and this was this was a trial that came out of IMvigor010, which indicated that while that was a negative trial looking at adjuvant atezolizumab, they had a signal that ctDNA positivity was going to identify patients who would benefit from atezolizumab, and the patients who were ctDNA negative did not, because they had a higher probability of being cured with the primary treatment. So here's what you're looking at in terms of overall outcome in terms of ctDNA negativity, an excellent prognosis. And then there's some elegant work being led by Lars Durskott in Denmark. This is the Tombola study. These are data that were presented now about a year and a half ago. Their intervention is also atezolizumab, and they're giving neoadjuvant therapy, curable disease here, and they're getting ctDNA at baseline. And Lars has shown in a number of really wonderful translational research projects that ctDNA positivity precedes detectable disease on cross-sectional imaging by usually at least 3.5, 4 months, and sometimes longer. And just here's some data from that study. And it's good if you're ctDNA negative, but as Matt will perhaps point out, it's not a guarantee of a cure until you follow those patients at least for a year. John Sfakianos had published this within the last year or two. John is a colleague of Matt's at Mount Sinai, and he had a cohort where he got ctDNA prior to cystectomy. And without going into a lot of detail, what he showed was that if you were ctDNA positive at baseline, that was associated with worse outcome long-term, even with cystectomy and neoadjuvant or perioperative therapy. And so now we're getting into an era where we can we should be doing trials getting ctDNA at baseline, and I'll show you some data for that. So Niagara was the trial that established combination checkpoint and chemotherapy as a neoadjuvant as a standard of care. You can see the outcomes stratified by ctDNA positivity or negativity at baseline. You can see the combination here in terms of event-free survival, comparing the combination treatment versus the chemotherapy alone, and it was prognostic in both of those groups as well as the total cohort. And then these are some data that were just presented by Michael Hayden at GU ASCO, extending this. I think one of the things that I found quite interesting was, so this is pathologic CR at radical cystectomy. So even if you were ctDNA negative at baseline, only half of those patients had a pathologic CR. But if you were positive at baseline, pathologic CR was really a very uncommon event. So people are starting to make some noise about, should we be offering what's the role of radical cystectomy, for instance, and in a setting where you're ctDNA positive? And I think that's an important research question, but that would have to be sorted out in clinical trials. So I was asked to mention briefly about UTDNA, so urine tumor DNA. So these are essentially, think about it as the correlate of ctDNA, which is in the peripheral blood, and now we're doing this in urine. And the technology has just taken off dramatically, where companies have figured out how to do sequencing of exfoliated cells in the urine. And so here's again some data that Michael presented in terms of UTDNA clearance from baseline pre-cystectomy. And here's the combination therapy versus the GC alone. So much better results with the combination, but still clearance was less than 50%. But then here you see event-free survival if you have persistent UTDNA. So what's the distinction? So this is telling us what's going on in the bladder. ctDNA is telling us what's going on in the periphery. So those two things in combination potentially could be very powerful prognostic um, uh, biomarkers. And here's just another look at pathologic CR based upon UTDNA negativity at baseline. And keep in mind that we know that in radical cystectomy only series, about 15% of patients will be path CR just with the TURBT alone. But we know that that number goes up to basically 1 out of 3 in patients who've had neoadjuvant chemotherapy, for instance. So some of these path CRs may have been path CRs at outset, but clearly not 72%. And then again, this look at the patients who are UTDNA positive at baseline. So this is, I love talking about Dr. Galski's clinical trial because it remains highly relevant. And he can talk circles around me with this, but this is a very important trial being conducted in the NCTN. Same patient population post-cystectomy, and in the ctDNA positive, now the randomization is to standard of care Nivo with or without a second checkpoint inhibitor, in this case, relatlimab. And then in the ctDNA negative, comparing standard of care to surveillance with crossover for patients who develop positive ctDNA during that first year, I think it is. So that trial's been accruing quite well, and we continue to support it and think it's important. In the last couple of slides, I just want to talk briefly. Now I'm back on bladder preservation. So this is some elegant work from Fox Chase, and this is their second retained trial where they're asking a question about bladder preservation in patients that get essentially, it's accelerated MVAC. Think about it as dose-dense MVAC plus checkpoint. So it's still a phase 2 trial, so sort of signal finding. And if they have an alteration in a DNA damage repair gene, ERCC2 being the canonical one, then they can go on to observation. If they don't, then it's physician and patient choice with a number of different interventions here. So that's the basic structure. And this was presented by Pooja Gatalia, a really lovely presentation at GU ASCO. And here they have baseline and post neoadjuvant therapy ctDNA, and you can see how it beautifully stratifies outcome in terms of metastasis-free survival. So this is ctDNA negative. These are patients who started out positive and then subsequently cleared with therapy. And then these are the patients who never cleared, which clearly have poor outcomes. And then here's the post-neoadjuvant therapy. Again, if you're ctDNA negative, you're looking really good. If you're ctDNA positive, we've still got some work to do to try to help those patients get cured. And then it was also associated with clearance of disease, but I think it's really important to know, and this is a very busy slide, but the take-home message is that clearance does not equal pathologic complete response. We're going to need UTDNA on top of that before we can declare these patients potentially cured. I think I'm going to skip this because it's a busy slide. And then the last two, UTDNA, I'm going to diverge a little bit to non-muscle invasive bladder cancer, where really the majority of the work has been done. And I'll just highlight one study that we did in SWOG. This was a trial of atezolizumab, single-agent therapy in BCG-unresponsive disease. And EuroAMP, the company is called Convergent, and we do have a collaboration with them in SWOG in this trial we did, and we were going to report some data from the PRIME study, which Rob Svatek presented at GU ASCO. Those data will be presented at the AUA. But basically, you can see that EuroAMP positivity at baseline was a little higher in the CIS population versus the papillary only. And the patients who had a CR at 6 months, almost the vast majority of them were UTDNA negative. And then you can see how positive negative stratifies patients in terms of outcome. Not a perfect outcome, because you can still see that 60% of the patients have had an event over a 5-year period, but it's certainly looking like we can stratify. This is baseline, and then this is at 3 months. which is a big benchmark for urologists in terms of evaluating complete response to therapy. And keep in mind, this is a patient population for whom cystectomy is still recommended by our guidelines, and we're trying to do bladder preservation in those patients. So this is interesting data that needs to be validated in trials that are actually designed to answer that question. So in summary, I think the muscle-invasive bladder cancer is a big spectrum of disease. We know that clinically, we know that pathologically, and we absolutely know that at the genomic level. Matt's going to get into the second bullet point in some detail. I deliberately kind of did not talk about this because he's going to go into this in detail, EV-Pembro neoadjuvant trial. And then I think that the field is really excited about the potential for both ctDNA and UT DNA, and I think you'll see a lot more coming out of that as we move along. So thank you so much, and I think we're going to go back to the poll. Okay, so I threw a lot at you, and I'll go ahead and just put this back up here. So remember, our patient has no high-risk features. We can debate, and Matt can get into this in a lot of detail about the appropriateness of cisplatin or the utility of using cisplatin-based chemotherapy in a patient with a slightly reduced EGFR. He has multifocal CIS. His tumor, I didn't tell you, is larger than 3 centimeters. The VIRAD's 2 and a negative PET CT. So I guess we'll do the poll now, I think. Is that right? Yeah. And I guess you tell me when the answers are going to show up. And I'll just walk through that very briefly. And I think I'm going to stop. No, I shouldn't stop sharing. So has everybody had a chance to? Yeah, okay. Wow, interesting. That's fascinating. All right, so briefly, we typically don't use intravesical BCG for patients with muscle-invasive bladder cancer. And I've tried to make that point that he definitely has muscle-invasive bladder cancer. Partial cystectomy is not appropriate because he's got a larger tumor, multifocal CIS. The chemoradiation therapy, I think that story still hasn't been told completely, but my intent was the multifocal CIS would generally rule this out. Interesting that nobody voted for cystectomy alone, and I think this would really be the appropriate therapy. And after discussing with his medical oncologist on Thursday, we're going to go ahead with that. And I'll go ahead and close. I'm going to stop sharing and turn it over to Dr. Galsky. And we'll be around, obviously, at the end for Q&A. So thank you all so much.
Thanks, Seth. That was great. I learned a lot, as usual. I'm going to share my screen. Okay, so we're going to start with another case. And this is a 67-year-old man who has hypertension. He has type 2 diabetes, creatinine of 0.9. He presents with gross hematuria, and he is referred to a urologist. He has a cystoscopy, which shows a bladder tumor. And we have another patient with clinical T2 disease, undergoes a staging CT scan, shows no evidence of metastatic disease. But he tells you that he's active, he plays golf, but he wants to do everything possible beyond, in addition to radical cystectomy, to try and reduce his risk of recurrence. He has an echocardiogram, which shows good ejection fraction. He has no significant neuropathy or hearing loss. You discussed the role of perioperative systemic therapy with him, and you recommend A, immediate radical cystectomy, B, neoadjuvant dose-dense MVAC for 4 cycles followed by cystectomy, C, neoadjuvant gemcarbo for 4 cycles followed by cystectomy, D, adjuvant Nivolumab for 1 year after radical cystectomy without neoadjuvant chemotherapy, and E, perioperative enfortumab vedotin plus pembrolizumab in conjunction with radical cystectomy. What do you recommend for this patient? And then we'll circle back to this at the end and discuss some of the answers. So I'm going to close out of that, and let's proceed. So there is some redundancy between the two talks, but they say in advertising, I think that you have to hear something 7 times before you remember it. So Some redundancy, but I'm going to try and highlight maybe some nuances of some of these studies. So it was actually pretty difficult to show that adjuvant therapy was beneficial in bladder cancer. There were decades of studies. They suffered from being small, underpowered, using suboptimal regimens. This was in the age of cisplatin-based therapy. And then a large study was designed by the EORTC, really was going to represent the definitive study here. And it was going to represent the definitive study because of a couple features. One was because it used contemporary regimens, so patients could receive adjuvant gemcitabine cisplatin or MVAC. And two, because they randomized patients to immediate adjuvant therapy or to the same regimen at the time of recurrence. That's been sort of a criticism of some adjuvant studies that really the question isn't one regimen versus the other in the adjuvant setting versus nothing, but using adjuvant therapy versus the same regimen at recurrence. So that was an attempt to try and normalize that across patients in that study. Unfortunately, that study closed early due to poor accrual, showed a disease-free survival benefit, was underpowered for survival. And so this question of whether or not we should give adjuvant chemotherapy in bladder cancer has always been a little bit unanswered. If you look at meta-analyses, most of the data support it, but we didn't have robust data. And then there was this gap for about 15 years where there was just no adjuvant studies being done or few adjuvant studies being done, no new drugs being developed in bladder cancer. And then came the immune checkpoint blockade era. And that really represented a major turning point in terms of the interest among industry, among investigators, among scientists, for developing therapies in bladder cancer. Those drugs were shown to have activity in metastatic urothelial cancer pretty early on in phase 1 studies. The response rate to single-agent immune checkpoint blockade in metastatic urothelial cancer is between 20 and 30%. So the minority of patients respond, but like in other solid tumors, when patients respond, responses tend to be quite durable. That led to the enthusiasm for that class of drugs in this disease. And of course, the logical strategy in oncology is to first show drugs are safe and effective in the advanced setting and then to move them earlier. So the first entry point for immune checkpoint blockade in muscle-invasive bladder cancer was in the adjuvant setting. And as Dr. Lerner pointed out, there were 3 studies that were designed almost identically with a few nuances. IMvigor10, which tested atezolizumab, Ambassador tested pembrolizumab, Checkmate 274 tested Nivolumab. All of these had disease-free survival primary endpoints, and then there was a co-primary with overall survival in the Ambassador study. Interestingly, 2 of the 3 studies met their primary endpoints, demonstrating an improvement in disease-free survival. Only Checkmate 274 has thus far led to regulatory approval. So as Dr. Lerner pointed out, Nivolumab is approved for patients with muscle-invasive urothelial cancer of the bladder with high-risk features after cystectomy. And pembrolizumab has compendia listing, I believe, in the NCCN. The IMvigor10 study with the atezolizumab didn't meet its primary endpoint. It was the first of these studies to read out, and it led to a lot of hand-wringing about why this didn't work. It works in the metastatic setting in some patients, why it didn't work in the adjuvant setting. And it turns out that IMvigor10, as Dr. Lerner pointed out, even though it was a negative study, turned out to be incredibly important for the field. And it was incredibly important because there was a molecular autopsy of the study, if you will. That is a determination of why this didn't work, and that was translated into a new prospective study. So that's really the way this is supposed to work. Figure out why our trials fail, try and understand whether or not things could be done differently, and then to test those new approaches. A really elegant example of that. So here's adjuvant nivolumab, as I mentioned to you, approved by the FDA in the United States for patients with high-risk pathological features after cystectomy. You can see the adverse event data here, and the adverse events that we see with adjuvant nivolumab are no different than we see with PD-1 blockade in any other clinical disease state. You don't see less risk for adverse events, but you see the same adverse events. So what was I getting at with the IMvigor10 study? Well, even though we see a benefit with adjuvant nivolumab, that benefit is real, and certainly this has become part of our standard treatment armamentarium. This is the value proposition here. This is the disease-free survival curves with placebo versus nivolumab. And you can see in the patients at the bottom treated with placebo who never have recurrence of their disease, obviously those patients didn't need any adjuvant therapy. They were cured already. Then we see the patients between these two curves, and that's the difference. That's where you see benefit with adjuvant nivolumab. And then unfortunately, you see the patients in the red here who have cystectomy and adjuvant nivolumab and still have recurrent disease. So we need biomarkers to guide adjuvant therapy, probably more important in this setting than in any other setting, because we're literally giving drugs to patients who have no cancer anymore. And we need to do things in a more precise way. Now, there's this notion that we need biomarkers to determine who benefits from treatment in the adjuvant setting, and that's absolutely true, but I would argue that we actually have a double biomarker problem here. So in the metastatic setting, we have a single biomarker problem. We have a bunch of drugs. We don't know which drugs work in which patients, and we need biomarkers to be able to pair the right drug with the right patient. In the adjuvant setting, we have a double biomarker problem. Not only don't we know which drugs work in which patients, we actually don't even know who needs any treatment. Oftentimes these get conflated because you can't benefit from a drug if you don't need a drug, but you can need a drug in the adjuvant setting and not benefit from it. And these are the patients in the red here. Obviously, they needed adjuvant therapy. They just didn't benefit from atezolizumab. And so we talk about these in the same breath, but I think they're actually separate biomarker needs. And I think determining who needs treatment has actually been lower hanging fruit here, and that's what Dr. Lerner was talking about with circulating tumor DNA. So ctDNA was applied retrospectively in the IMvigor10 study, that study that didn't meet its primary endpoint, and it was shown to enrich for patients who benefit from atezo, leading to the prospective IMvigor11 study. The ctDNA platform that's being used across virtually all of the studies that we've spoken about this morning is the Signatera platform. So this is tumor-informed molecular residual disease testing. This is a commercially available platform. In the IMvigor11 study, the eligibility criteria were virtually identical to the rest of the adjuvant studies that I showed you, with one exception. After surgery, patients underwent ctDNA testing. If they had detectable ctDNA, they were randomized to atezolizumab versus placebo. If they had undetectable ctDNA, they were monitored every 6 weeks. And if they had conversion of ctDNA from undetectable to detectable, then they entered the randomization. It's sort of an interesting design. The primary endpoint of atezo versus placebo in patients with ctDNA detectable assays is actually pooling data from patients who had detectable ctDNA immediately after surgery, our traditional adjuvant setting, and then patients who had that later molecular conversion. Whether or not biologically those are actually the same thing, I think we don't know for sure. One can argue. But the results were broken down also independently in those two different cohorts, and I'm going to show you that in one moment. So here's the consort diagram from the study. 607 patients were included. 459 had undetectable ctDNA after surgery. So the majority have undetectable ctDNA after surgery. And Dr. Lerner showed you that curve showing patients with persistently undetectable ctDNA. Looks very promising. I would just a word of caution about interpretation of that. Those are patients who have persistently undetectable ctDNA. And that is very important data. It makes one feel confident each time you see that negative ctDNA test that your patient is doing well. But it is a little bit just the notion of conditional probability. That is that the longer an event doesn't happen, the less likely it's going to happen. And each time a patient has a negative CAT scan, there's a lower likelihood that they're going to develop metastatic disease as well. The issue is that we generally need to make treatment decisions sooner than that, like right after surgery. So 459 patients had undetectable ctDNA after surgery, but 102 of those patients actually had molecular conversion during the first year. So an undetectable ctDNA test right after surgery does not mean someone is quote unquote out of the woods. But whether or not those patients would have been better off being treated right after surgery, that we don't know for sure. We're trying to answer that question in the modern study that Dr. Lerner had shown the schema for. So here's the outcomes of those two groups that I was talking about independently. The top are patients with detectable ctDNA right after surgery, a traditional adjuvant population. And you can see there's an improvement in disease-free survival and overall survival with atezo versus placebo. So IMvigor10, there was nothing wrong with IMvigor10 about the scientific hypothesis. It wasn't an outlier because the scientific hypothesis was wrong. It was an outlier clearly because patients were not enriched for those with micrometastatic disease, and I think IMvigor11 proves that. In the bottom part, you see patients who had molecular conversion, and you see a similar effect size for disease-free survival and overall survival if you treat patients upon molecular conversion. And I think this is a really, really important observation. To my knowledge, this is one of the first, or maybe the first, demonstrations in a solid tumor that you can meaningfully impact molecular recurrence with ctDNA, no evidence of disease on scan. You can treat patients based on detectable ctDNA during serial follow-up, and that leads to an improvement in time to event outcomes. So important data there. And again, we're studying those concepts further in the modern study being done through the cooperative group system available throughout the United States. Here's the data that I was alluding to with persistently negative ctDNA. And again, when you have persistently negative ctDNA, then you stay on this curve, and the curve looks really good. But remember, all of those patients who had a baseline undetectable ctDNA and conversion to detectable ctDNA, those 22% of patients who had that happen during the first year, they're taken off this curve. So these are only patients who stayed negative, and again, the concept of conditional probability. So the adjuvant space is heating up. We're starting to develop precision biomarker-guided approaches in the adjuvant setting. And while those studies are being done, things are moving ahead in the neoadjuvant setting. And what's happened in the metastatic setting, of course, is that our standard of care has changed. The EV302 study, initially presented at ESMO in 2023, demonstrated that the combination of an antibody-drug conjugate directed against Nectin-4, enfortumab vedotin, given in combination with PD-1 blockade pembrolizumab, improved outcomes compared to platinum-based chemotherapy, the drugs that we had been using for 30 plus years in this disease. And so EV-Pembro became the new standard of care in metastatic disease, and the logical question was, should we move those drugs earlier to the neoadjuvant setting? And so there are two studies testing that concept in the perioperative setting. And when I say perioperative, some people refer this as a sandwich approach. That means that the drugs are given both before in the neoadjuvant setting and then after surgery as well in the adjuvant setting. So two clinical trials testing that concept with EV-Pembro in patients who are cisplatin ineligible. And remember, historically, in patients who are cisplatin ineligible, we had no neoadjuvant therapies that had demonstrated benefit, so patients were recommended to go directly to cystectomy. So the control arm on these studies is cystectomy alone. And then the experimental arm on one study is EV-Pembro. On the other study, it's durvalumab plus EV or durvalumab plus tremelimumab, the CTLA-4 inhibitor plus EV. Keynote 905 has read out, was presented at ESMO, now published in the New England Journal of Medicine. Volga has not read out yet, and I'm gonna show some of the details of Keynote 905. So here's the study design again. There was an arm. So this study actually started as Pembro, perioperative Pembro alone, versus cystectomy. And then during the early conduct of the study, the EV Pembro data came out in the metastatic setting, and it was logical that that arm should be added. So that became the primary arm, being compared to cystectomy alone in Keynote 905. Primary endpoint was event-free survival, key secondary endpoints of overall survival and pathological complete response rate. Here you see the primary endpoint of event-free survival, a hazard ratio of 0.4. If you were not a believer that perioperative or neoadjuvant therapy improves outcomes in patients with muscle-invasive bladder cancer before, hopefully this data pushes you over the edge. Clearly a major benefit in this study. Here's the overall survival data. Similarly, a impressive improvement in overall survival with a hazard ratio of 0.5. And here's the path CR rate. And the path CR rate with EV Pembro was 57.1%. Just a little sort of side note, that a lot of times we have some sense of the path CR rate for a novel regimen because a bunch of phase 2 studies had been done before the phase 3 study. We actually had no phase 2 data with neoadjuvant EV Pembro before these phase 3 studies read out. And so everyone was hoping for a pretty high path CR rate. No one knew exactly what it was going to be. But now the majority of patients achieve a path CR with EV Pembro, which is really a different place than we were with the early days of platinum-based chemotherapy. This regimen is not without a downside for those who have used it in the metastatic setting or maybe in the perioperative setting. There are side effects with EV Pembro. There's all the side effects that can occur with immune checkpoint blockade. There's the side effects with EV, which include things like peripheral neuropathy, rash, fatigue. However, compared to in this study compared to cystectomy alone, of course, we see higher rates of many of these adverse events. In a study comparing to chemotherapy, the trade-offs become obviously quite different. So in cisplatin eligible patients, there were two different strategies that were pursued. One strategy was combining cisplatin-based chemotherapy with immune checkpoint blockade. The other strategy is EV Pembro. We have three very similarly designed studies asking whether or not we should add PD-1 or PD-L1 blockade to standard neoadjuvant cisplatin-based chemotherapy: Niagara, Energize, and Keynote 866. Notably, we've only seen the results for one of those studies, even though they were launched a while ago, and that is the Niagara study. I'm going to show results from that very briefly. Keynote 866 and Energize, we haven't seen the results for. And then Keynote B15, the EV Pembro study, we just saw results for at ASCO GU, and I'll show some of those results. So here's Niagara, standard muscle-invasive bladder cancer population, randomized to 4 cycles of gemcitabine cisplatin versus gemcis durvalumab, and then durvalumab was continued in the adjuvant setting for 8 additional cycles. Primary endpoint was event-free survival and path CR rate. Here you see the event-free survival significantly improved with gemcis durva versus gemcis, leading to an FDA approval of this regimen. The benefit in EFS was really seen across all major subsets and demographic groups. And here you see the overall survival data as well. And overall survival data showed an improvement really at the first readout of this study, and solidifying the its role as a primary, as a standard treatment option. Keynote B15, as I was alluding to, randomized patients to EV Pembro in the perioperative setting, so both before and after cystectomy versus standard gemcis followed by cystectomy. This we saw the results for at ASCO GU this year, designed from an endpoint perspective very similarly to Keynote 905, primary endpoint of event-free survival, key secondary endpoints of overall survival and path CR rate. And here you see again a nice improvement in event-free survival with EV Pembro versus platinum-based chemotherapy. Now remember, here an active comparator rather than cystectomy alone in Keynote 905, but we see an effect size with a hazard ratio of 0.53. And here's overall survival with a hazard ratio of 0.65. So EV Pembro in the perioperative setting is now approved by the FDA for patients who are cisplatin ineligible based on Keynote 905. We haven't seen regulatory decision making specifically based on Keynote B15 yet because, of course, this is very new data. And here's the path CR rate from Keynote B15. A path CR rate of 55.8% lines up almost identically with what we saw in Keynote 905. And here's the adverse events that I was referring to before. And you see here, now there's trade-offs because we have an active comparator systemic therapy. And so the side effects are different with EV Pembro versus Gemcis. With Gemcis, you see more cytopenias, you see more nausea. With EV Pembro, you see more pruritus, you see more rash, and you see neuropathy that's a little bit higher. Immune-related adverse events are common, not common, are side effects that are common to all of those regimens that I mentioned, Gemcis, Durva, or EV Pembro. PD-1 or PD-L1 blockade causes the same constellation of immune-related adverse events, which I'm sure you're all experts in diagnosing and managing now. Any organ system can be affected. We all know this very nice figure showing the timing of when we expect these events might happen. But of course, in clinical practice, we see things across the board. We see patients develop these side effects rarely, but it happens after one dose of immune checkpoint blockade. And we see patients develop these side effects after 2 years of treatment. So it really is across the board. Any adverse event, any new sign or symptom in a patient getting immune checkpoint blockade is a side effect of that drug until proven otherwise. That's the approach that we've generally taken because of course, patients don't present like they do in the textbooks, and you have to extract information to not miss these diagnoses because, of course, early diagnosis and intervention by stopping immune checkpoint blockade and giving steroids when indicated is critically important in making sure that the side effects don't cause any longer lasting sequelae. And here's just the general approach to managing immune-related adverse events. Of course, there are very nice guidelines for managing specific events through multiple resources, including the ASCO publication on guidelines for management of immune-related adverse events. So I'm going to stop there. We're going to return to our case. And remember, this 67-year-old man, he has some comorbidities. He has hypertension, he has diabetes, good kidney function. He has clinical T2 disease, and says that he's quite active. He wants to keep golfing. He is certainly amenable to having a cystectomy because he understands that's a pillar of curative treatment for this disease, but he wants to do everything possible. And so you discuss the role of perioperative systemic therapy with him, and you recommend immediate radical cystectomy, neoadjuvant dose-dense MVAC, neoadjuvant gem-carbo, adjuvant Nivo, or perioperative EV Pembro. What do you recommend? And there's apologize in advance. There's a little bit of a trick question or nuance to this one, but I framed the question in this way because it represents real-world clinical practice now, and it highlights a point that I wanted to talk about in more detail. So go ahead and log in your answer, and we'll get the poll, and then we'll discuss briefly the results. I think we're coming up on time here. Okay, what do we have? So we have answers across the board. We have 11% immediate radical cystectomy. We have neoadjuvant dose-dense MVAC, 22% neoadjuvant gem-carbo, 22% adjuvant Nivo, 11%, and then a third said perioperative EV Pembro. So I'm interested in Dr. Lerner's comments. I would say maybe I'll just start with C, 22% neoadjuvant gem-carbo. So we really don't have good data for carboplatin-based chemotherapy in the perioperative setting in bladder cancer. We know that in patients with metastatic disease, carboplatin-based chemotherapy seems to be inferior to cisplatin-based chemotherapy, even though we don't have definitive large phase 3 studies testing that concept, and this has been a debate in the field for decades. We don't have good data for perioperative gem carbo, so I wouldn't recommend gem carbo in this setting. Dr. Lerner, what do you think about this one? There's some nuances here.
Yeah, no, it's interesting because, first of all, that was a brilliant presentation and a real
Thank you.
tour de force. So thank you very much for educating us. I'm thinking about this conversation I had with my colleague on Thursday about the patient that I presented, and he reminded me, and we went back and looked at the current iteration of the NCCN guidelines that chemo, in this case, cisplatin-based chemo plus checkpoint, I assume that's GC Durva, based upon the Niagara trial, has a category 1 recommendation. EV Pembro is listed as an option, but not a category 1. I imagine that that's yet. I actually had a question about that is, for can you write for EV Pembro in the neoadjuvant setting today and get insurance approval, or are the payers still going by this category 1 recommendation for either platinum-based chemotherapy alone or platinum plus ICI?
So we've been able to prescribe it with one phase 3 study in a similar patient population, and the other phase 3 study presented but not published yet. We've been able to prescribe it. I understand why that might not be possible everywhere, and that's why there is a nuance to this, and B, I didn't put, you'll notice, gemcitabine to try and not make it too confusing. The other nuance to this situation, of course, similar to the prior case, is that this patient was deemed to have clinical T2 disease, and this has been a struggle, or a complexity rather, of the field in terms of our difficulty clinical staging patients. So, Dr. Lerner, what do you think about that?
Yeah, no, you bring up a great point. And that's why I kind of threw in the PET CT and MRI, because I think a lot of us have started to use that. I think MRI use is much more prevalent in Europe, where the whole VIRADS system was developed, and I think they've been a little quicker to implement it. But if you look at the SWOG 1011, which was a clinical trial randomizing patients to extended versus standard node dissection, we had 70% uh, clinical T2, and a lot of those patients were just simply understaged pathologically. And so we need to get closer to, I'll throw out a term, precision clinical staging. And I would encourage folks to use MRI. You need to talk to your radiologist, though, so that they can implement the VIRADS scoring system. It's not that difficult. I do want to come back to ctDNA and the role that that plays. But it's really incumbent upon the urologist to try to get as many data points together to try to get a little bit closer to understanding what's the likelihood that you have a pathologic muscle confined versus non-pathologic. Because I would argue that it's a no-brainer for patients who are T3 or greater that they should always get neoadjuvant therapy. And I think the only other thing I would say is that all of us need to be working together. And you could argue that that also ought to include the radiation oncologist. Patients really need to have the benefit of getting counseled on their treatment by the multidisciplinary team.
Absolutely.
Um, yeah, we do have time for questions. I guess these need to appear in the chat if anybody has anything. But Matt and I will continue this discussion while you're thinking about your questions. We both kind of talked a lot about ctDNA, and I think that, I mean, Dr. Galsky and I live in a world of clinical trials. We both have responsibilities as leaders within our respective cooperative groups, and I think that we're always going to favor putting patients on a clinical trial. But not everybody has access to clinical trials. These data on ctDNA are filtering out to the community. What would you tell those of folks who are working in say, a private practice or even an academic environment, how we should be using, how should we incorporate ctDNA into our practice and specifically treatment decisions? What do you think?
So I would say from my standpoint, the only establishment of clinical utility for ctDNA testing right now in muscle-invasive bladder cancer is determining who needs adjuvant therapy, not who doesn't need treatment. And that's a nuance, right? So you see a patient after cystectomy, Signatera testing, and there are some other commercial platforms. So I don't mean to plug one platform versus another, but Signatera is commercially available, and all the data that we showed you is based on that platform. So if a patient has detectable ctDNA using Signatera after cystectomy, that patient needs adjuvant therapy. Now, they might not want it, and that's a very personal decision, but from a need standpoint, I would argue that patient needs it. And if they're on the fence, like many of our patients are about receiving systemic therapy, then that could be the data point that pushes things over the edge. If you have a negative ctDNA test, should that patient not get adjuvant treatment? I don't think the data is quite there yet. Hopefully, modern will fill in that gap. But if they have a detectable ctDNA test, that should push the decision over the edge.
So the as it relates to this specific assay, Natera, since that's where all the data, at least to date's been generated, we generally need to wait at least 4 weeks, and I would say ideally probably 6 weeks post-surgery in this case to get the assay. So we want to wait for all of this to clear out, so to speak, after surgery. And then I think it's worth emphasizing the serial testing. So if I understand correctly from the company, if you order that test, let's say in the postoperative setting, it becomes a turnkey operation. They'll automatically get that at 3, 6, 9, and 12. They'll come out to the patient's house and draw the blood if they want. But I think that you made a very important point that it's not the baseline ctDNA negativity is great. It's good if you're in that state, but you need to be followed because, Matt, I think I remember about a third of those patients, 30% will convert to positive in that first 12 months, excuse me. And that's a signal that they need adjuvant therapy. Is that a framework that our audience can use?
Yeah, I think that's quite reasonable. The again, I would say that if you have a negative test after surgery, I don't know that we're quite there in terms of counseling that patient not to receive adjuvant treatment because we don't know that treatment upon molecular recurrence is as good as treatment right after surgery. We know that treatment upon molecular recurrence can improve outcomes, but that's not compared to treatment right after surgery. So we don't know that for sure. But I think that's a reasonable framework. I would say that, InVigor11 did testing every 6 weeks. So if you're a purist and you want to recreate the what was done in the study, then that's actually less frequent than was done in the study.
Yeah, that would seem a little intense just to me, but I'll leave that to others to decide. So we're in this really fascinating time where we're finally getting some biomarkers. I also just want to emphasize, and the urine tumor DNA is not really ready for prime time. We need to get a lot more data on that and study that prospectively, much as has now been done with ctDNA. But just for the audience to remember that, ctDNA, what's going on in the periphery, utDNA, what's going on in the bladder. And I think the other thing in the bladder preservation setting, we're not quite there yet with actually both assays. Not surprising that if ctDNA sort of turns out to have the same kind of signal in bladder preservation, but it becomes really important to figure out those patients who are not cured from a local disease standpoint in the bladder preservation setting. And I think urine tumor DNA will help with that a lot, but we still have a lot of work to be done.
So Seth, we just published in PNAS um,
ah,
urine
oh yeah, that's right.
urine tumor DNA plus ctDNA, and I think to your point exactly, if you have a clinical complete response to treatment and undetectable UTDNA, your prognosis is or your risk of recurrence within the bladder is very different than if you have detectable UTDNA.
Yeah, yeah. I don't see any questions. Matt, I'll let you have the last word, and then I think we'll say
Uh,
goodbye.
I think this was great. Always great to have these discussions with you. I learn something every time, and thanks everyone for attending today.
Yep. Thank you. Enjoy your weekend, everybody. Thank you for joining us. We'll see you.